speaker now. So our speaker received her PhD in epidemiology and mathematical modeling from the Institute of Medical Science at University of Toronto, then continued on to a postdoc with the Prevention Policy Modeling Lab at Harvard T.H. Chan School of Public Health. She was also the senior epidemiologist at the Canadian startup Blue Dot, that you might remember was the first AI-driven forecasting that kind of warned customers that there was an emerging pandemic or epidemic or something going on in Wuhan before it was well known to the world. And then in March 2020, she became an assistant professor at the University of Toronto Dalla Lana School of Public Health and has since served on Ontario's COVID-19 modeling advisory table and helps guide policy around vaccination, masking, and testing. She's actively engaged with the public through media, interviews, and Twitter to spread policy awareness and guide safe reopening strategies. And we're all very excited that she took time to speak with us today on her work. So please join me in welcoming Dr. Ashleigh Tuite.
Thank you so much. That was a really nice introduction. I maybe need to steal that from you so I can provide it for other talks. Just by way of disclosure, as of the beginning of September, I've actually started working as on secondment at the Canadian National Advisory Committee on Immunization Secretariat. So I still maintain my link at U of T and I'm there part-time. And what I'm presenting today is in my role at U of T and does in no way represent the Public Health Agency of Canada's views. So just wanted to make that clear. So in terms of what I was hoping to talk about today, I do have some slides, but I would also please, if you want to interrupt me or ask questions or pause at any point, please do. I don't have a ton of slides and hoping to leave lots of time for discussion at the end as well, but I encourage interruptions during as well. So just sort of put that out there. And so what I was hoping to talk about today is, I would say this is a science talk, but it's also a bit of a policy talk in the sense that I wanted to talk a little bit about what's been happening in Ontario, Canada throughout the pandemic. And what's been sort of unique for us is that, I'm coming at COVID research from an academic perspective, but there's been a high degree of interaction with government. And one thing that's been really unique is that academic groups have been granted access to the provincial public health surveillance system. And so that's really resulted in, I think, a really good synergy and has really, sort of mapped the way that our province has responded to the pandemic and has also created, I think, for researchers, an interesting paradigm, which is not something that existed before COVID. So just to provide you all with a bit of background, Ontario is Canada's largest province. It's home to 14.7 million people. As of yesterday, we had a little over 500,000 reported cases. So that represents about 4% of our population. We've had around 9,700 deaths, so 66 per 100,000, which, in Canada has been considered, a pretty big epidemic. I realize talking to many of you, this may seem like a, not such a big or pandemic experience compared to what you may have seen. One of the really defining characteristics of the first two waves of the pandemic in Ontario was that it devastated our long-term care homes. That situation changed with vaccinations, but we had about 3% of cases in long-term care home residents, but over 40% of our deaths were in long-term care home residents. We're currently in our fourth wave, and we have a little over 70% of the entire population fully vaccinated. So that's individuals, vaccines have been rolled out in individuals age 12 and older. I'll go into a little bit more of the epi data in a moment, but I just wanted to provide you with a quick overview of how public health surveillance works in Ontario. So in the province, we have publicly funded healthcare. Testing is provided for everybody via both public and private labs. But all of that information is funneled to a single provincial repository. So we have information on everybody who has been tested. And for all of the test positive cases, we have information on their demographics, some risk factor data, as well as outcome data. So we know what, when, and if a person is hospitalized, requires ICU care, or dies following infection. Screening for variants of concern began systematically in February of 2021, and the approach to screening has really evolved over time. So initially it was, specific screening tests for known VOCs, and at this point, around, if I'm not mistaken, around 50% of all positive tests are sequenced. So at this point, we have a pretty good handle on the sort of circulating variants. The information that sort of is provided to academics isn't the really sort of detailed genomic sequencing information, but we do know for every case what they've been classified in terms of their VOC status and what particular VOC or what particular mutations they have. We also have a single database for COVID vaccinations. So for every person who's been vaccinated in the province, we know when they've been vaccinated with what vaccine product. And I'll talk a little bit more about that in a moment, because our vaccination experience, I think, has been pretty unique in Canada. And that vaccination data is also linkable with the case data. And as I mentioned earlier, the access to the data is provided to academic groups via a mechanism that is called the Ontario Science Table. And there's also another group called the Modeling Consensus Table. And these groups were really formed during the very early stages of the pandemic, when it was clear that we needed some sort of systematic approach to making sense of the data. And this really started with modeling projections in terms of where things were headed, and really evolved into a group of independent academics who were able to provide information about what was happening during the pandemic, do rapid evidence reviews, etc. And so this is just a graph showing what the waves of the pandemic have looked like in Ontario since this is March of 2020 up until 2 days ago, broken down by age. So as you can see, our first wave was basically a long-term care home epidemic. It was quite devastating. And our second wave was similar. We had really high numbers of cases in older people, but we also started seeing an increase in cases really across all ages. Alpha was first identified in Ontario in December and really began to take over in January, February of this year. And our vaccines were approved in Canada in December. Really became widely, or I wouldn't say widely available, became sort of available in January. And the initial focus for vaccinations was in vaccinating healthcare workers as well as long-term care home residents. And so what you see here is this pretty rapid drop in the dark blue line, which represents the protection of long-term care home residents. We experienced our worst wave in the spring of this year, where, despite the fact that we had vaccines and we were starting to roll them out, the emergence of Alpha really was just too much to countervail what was happening with our vaccine program, which was, not rolled out super fast because of issues around supply. And so we did have this very bad third wave. And then sort of towards as this was peaking, we had the identification of Delta in Ontario. And at this point, Delta is essentially all of the cases that we identify right now. And yeah, now this is where we are now. We have what looks like a fourth wave, but it's been a bit confounding to people in the sense that things are not really taking off. And you know, we're all sort of holding our breath and waiting. And just wanted to zoom in a bit here to show you, if you can see this dark red line are the under 10. So this is the unvaccinated, or the biggest unvaccinated group in our population. And so while most of the other groups are, you know, either stable or going down, we are starting to see this increase in unvaccinated school-age children. And that's something that I think we were expecting with the return to school in September. It hasn't been as explosive as we might have expected thus far. And in Ontario, we do have lots of public health measures in place in schools. Masks are mandatory for all children, except for kindergarteners, if I remember correctly. And there's also been a focus on ventilation and other measures to try and protect that particular age cohort. And then, sorry.
Actually, there's a question in chat.
Yeah.
So Jennifer asked, both the Alpha and Delta waves seem earlier than in the States. Is that a correct assessment, or was it just more visible and more quickly controlled since Canada had less disease?
I think it was earlier. I mean, we certainly had, I think for Alpha in particular, and actually Delta as well, we really seem to have it take off earlier. And I'm not really sure why, if it's maybe a sort of the fact that we're smaller and, you know, sort of founder effects or what was going on. But yeah, we did, for Delta in particular, I would say we were, you know, by July, it was the predominant circulating strain.
And then there's one other question from Darlene, sorry. Yeah. How common are proactive testing campaigns, testing of asymptomatic individuals?
It's varied. The approach to testing has really evolved throughout the pandemic. At this point, you know, there is, I guess there are a couple of of branches to that question in terms of, you know, testing of high risk contacts. That's something that has really ramped up and down depending on resources. So at the peak of the various waves, that tended to sort of get thrown by the wayside. And then when there were more resources, there's increased focus on contact tracing of sort of asymptomatic contacts of known cases. The asymptomatic testing in general is something that's actually become pretty controversial in the province right now, particularly as relates to schools and rapid tests. It's something that in the province, we have a lot of rapid tests, and they are being used by workplaces. Many, and in many cases, those are workplaces where people are highly vaccinated, but those tests haven't been deployed to schools. And that's actually a huge source of sort of outrage, at least on social media. And, you know, you're having sort of parent groups that are trying to organize these sorts of campaigns to incorporate in asymptomatic testing in those populations. But it's, at this point, it's pretty controversial and really not widely accepted, and something that public health is discouraging.
Thank you. That's really interesting to hear.
Yeah, welcome. Yeah, this is just another way to show that, you know, what we've seen over the last couple months as we've had vaccination in our adult population, adult and adolescent populations, is that the share of cases that are due to the under 10s has been increasing as you would expect. Having said that, vaccination has been highly effective. Again, I don't think this is news to anybody, but amongst the cases that we're seeing the majority of severe illness is concentrated in people who are unvaccinated. So the orange lines in these different graphs here. I wanted to talk a little bit about our vaccination approach because I think this may be interesting or relevant to you all. We had a situation where we bought a bunch of different vaccines. So basically not knowing which was going to be the vaccine that was most effective, we bought Pfizer, Moderna, AstraZeneca. And because of supply issues, they became available at different times. So early on, we had a lot of Pfizer, and then sort of later on in the spring, we had a glut of Moderna. We had some AstraZeneca, and then there were, issues around, essentially what vaccine which people should get. So what this graph is showing is essentially, we've administered more than 21 million doses, and sort of what the boxes outlined in yellow are showing what a person received for their first dose. So the majority of people received Pfizer for their first dose, but then a subset of people who received Pfizer for their first dose received Moderna for their second dose. Amongst people who received Moderna is a smaller group segment of the population, but a subset of those for their second dose received Pfizer. And then for AstraZeneca, we had a really interesting situation where a lot of people, or a significant number of people received AstraZeneca for their first dose. And then the guidance from our sort of immunization policy groups changed such that it was recommended that people receive an mRNA vaccine for their second dose. So we've had a lot of mixing of doses. And I know that in the US, that's not really been an issue because you've had abundant supply. But I think this is relevant, as you're talking about boosters and, the safety of mixing doses. I would say that, most people, myself included, have had the experience of receiving different doses for their first and second, different vaccine products for their first and second doses. And I think it's an area that is interesting, and in terms of thinking about the sorts of questions we can ask in Ontario, at this point, that's an area that's of active interest in terms of thinking about durability of protection and need for boosters and whatnot. This is another figure that just sort of captures the changes in our vaccination approach over time. So this graph on the left is showing the interval between first and second doses timed by the month of the first dose. So in December, when vaccines were first approved, we had Pfizer predominantly available, and we stuck to the 3-week interval. What you see here is that in January, we also had access to Moderna. So there are 2 humps. And then you start seeing these sort of spreading out. And what that represents in terms of the time between the 2 doses is that we had alpha emerging in our population, and we didn't have enough vaccine supply to be able to give everybody their 2 doses at the recommended 3 or 4 week interval. And so it was decided that it made more sense to get more people vaccinated with their first doses and extend that interval. And the recommendation was that people could receive their second dose up to 4 months after their first dose. And so that's what you see here. And then over time, as more vaccines became available, we've essentially shifted back. So we're closer to the recommended intervals. And this is a source of a lot of interest, because at this point, I think the data are suggesting that these extended intervals are actually optimal. And so, over time, we'll be able to look at that and get a sense of, differences in protection depending on interval between doses. And this figure on the right is just showing, because of how vaccines were prioritized, we focused on age predominantly. We have, in terms of trying to make sense of the data, they're going to be highly confounded in the sense that, different people had very different intervals between doses by age. because, as younger people were getting access to vaccines, there was more vaccine supply. So they were more likely to have shorter intervals between doses. But yeah, that's sort of the the messy situation that unfolded in Ontario and in most of Canada as well, as we attempted to adapt our vaccination to what was available and what made the most sense at the time that we were rolling out the vaccines. Sorry, I'm just oh, sorry.
Question, actually.
Yeah.
Have you all considered, or are you implementing boosters for those who got the initial shots in December with no gap in between?
Yeah, no, it's a great question. So far, we've only recommended boosters in long-term care home residents who would be predominantly those people who received the early doses with the short duration. I think moving forward, we're working through the recommendations because healthcare workers would also be included in that initial short period of time. And at this point, there hasn't been any recommendation that they receive boosters. But I think it's a source of discussion right now to determine exactly what we should be doing.
There's another question in the chat about this figure and whether or not the graph on the left is representing a new set or mixture of vaccines being available. So is the color related to any of the mixing of vaccines, or is it just
No,
to distinguish them?
It was just there to sort of help differentiate between time, but that's actually a really great idea. That would be nice to look at, is the doses as well. Because yeah, there's a lot of dimensions that are happening here. But yeah, I just did it for contrast.
And then one more question in the chat was whether or not you had any plots around the testing volume among age groups over time, but I'm guessing due to the controversy in the schools that it's highest in the oldest or just the working population.
So I actually do, but I don't have it included here. It's something that I look at. This was one of the graphs that I guess I should say, in terms of the stuff that I'm sharing with you, we run these analyses kind of every day just to get a sense of what's going on. I don't have it included in here, but it's kind of relevant to what I wanted to what my next slide is on, which is because we have the test data, we are able to get a better sense of what's actually happening in the population. And so this is an analysis that we did. It was from early on in the pandemic. So it used data from March to December 2020. So it really missed our big second and third waves. But what's shown here is on the bottom are the reported cumulative incidence per 100,000 populations by age. And really what you see here is the highest incidence based on how we were testing in the population was in the over 80 groups. And that really reflected the fact that, we were testing those people because they were symptomatic, and we were actively monitoring what was happening in long-term care homes. And, by contrast, we had, relatively lower rates in younger individuals. But we were able to do an analysis where we essentially were adjusting for testing frequency and did a bit of a thought experiment, which was to say, if we had been testing the rest of the population at a rate that was similar to the testing rates in this oldest age group, what might those pandemic waves actually have looked like? And so what's shown here is estimated cumulative incidence over this period of time. And really what we see is a very different picture, which is that, as much as we were really seeing cases in the realistically, the over 80 age group, what is more consistent with, had we been testing more equally across the population, we would have expected to see much higher rates in the 10 to 30-year-old age group. And again, I think, based on studies that are coming out now, like the serologic studies, are consistent with that, which is that, we were seeing a very distorted view of the pandemic because of how we were using tests. And, that's continued to date as we change the testing criteria. I guess the next thing I wanted to talk about was variants of concern, because we do have really good surveillance in terms of what's happening. This is a little bit out of date. This only goes up to the end of June, but is showing the emergence of the VOCs. So in February, we really were starting to see the N501Y positive variants of concern, predominantly alpha, but we did also see beta and gamma. And then in April, we really started to see the emergence of delta. And as I said, at this point, it's taken over. And we saw something similar when we were looking at severe outcomes. So you see this displacement of the cases that were hospitalized, admitted to ICU, or died first by the N501 positive VOCs and then subsequently by Delta. And another way that we were able to really, or I guess another clue that we had that, there was more going on with respect to these VOCs than just, increased transmissibility, was by looking at the ICU admissions. So early in the pandemic, we developed a prediction rule or a prediction model where we were able to estimate the number of cases that would be admitted to ICU in a given week based simply on the number of cases that were reported 2 weeks prior, the number of tests that were performed 2 weeks prior, and the mean age of cases, again, with a 2-week lag. And it was a pretty good prediction in terms of, our ability to estimate what was going to happen with ICU admissions. So that shifting age in cases was something that was really important. As we started seeing cases in younger ages, we also started seeing reduced ICU admissions. Once VOCs became established in the population, so this is sort of winter of this past year, our ability to use this prediction rule failed. We were underestimating, particularly in this third wave, the number of ICU admissions if we were simply using lagged tests, cases, and mean age. And really what we found is that we needed to include not simply vaccination. So we've started by adding vaccination into the vaccination coverage into the model, and that wasn't sufficient. So we ended up having to add in the percent of alpha and delta. And when we did that, we were able to estimate ICU admissions, which was suggesting that, we were dealing with a more virulent pathogen as these VOCs emerged. And so using the Ontario data, we were able to go in and actually look at the relative risks or the odds of hospitalization, ICU admission, and death amongst cases who were either infected with Delta or an N501 positive variant. And what we saw were these elevated risks associated with these variants. And this is something that's been confirmed in other groups. I think the hospitalizations are the most robust estimates just because of the absolute numbers of individuals who have been hospitalized. But we consistently see this analysis was conducted in the summer, and since then we've seen this seems to be a really robust finding in that we do see these elevated risks of ICU admission and death. And this was something, a question that we had was, we see this elevated risk with infections with N501 positive cases, but I think more strikingly with Delta. And at this point, Delta is more relevant because it really is the virus that is circulating right now. And there was this question of whether it was consistent across ages or if this was something that was really concentrated in older individuals. And so we did an analysis looking at risk by age groups. And what we see is, for hospitalizations, and I'll focus just on the Delta, we see a pretty consistent effect of increased odds of being hospitalized across ages. We again, see a consistent effect for ICU admissions, with the caveat that we have very low numbers of cases in the younger age groups. So there, the confidence intervals cross 1, and we actually were not able to do the analysis for the under 10-year-olds just because the outcome is so rare, thankfully. And similarly for death, we have very few deaths in under 30-year-olds, so we're not really able to look at that. But amongst the cases that we do see, what we see is, if anything, and again, very large confidence intervals here, something of an elevation of risk in the 30 to 50-year-olds. And this is adjusting for things like vaccination status and underlying medical conditions. So again, I don't think this is necessarily groundbreaking, but I think it's something where, the narrative has been, well, kids are protected and we're not, the changes that we're seeing with the emergence of these variants of concern is not necessarily something that translates down to kids. And this suggests that, that is not the case. It affects, not just kids, but younger people in general.
Actually,
yeah.
So on that analysis, you had mentioned that you controlled for vaccination status. Are you able to actually see whether this increased risk depends on vaccination status? Like, does odds of 2 for like an unvaccinated person increased risk of 2 versus a vaccinated person increased risk of 2 for the Delta? Like, I guess is there any effect of vaccination status on the impact Delta's having?
So we didn't look at it within the age groups, but we did in the sort of aggregated analysis. And we've seen, as you would expect, the vaccination is highly protective against all of the outcomes. I'm not sure if that's what you're asking. If you're looking at, you mean like an interaction between, which we haven't looked at.
I'm wondering the interaction.
Yeah, no, it's a great question. We can certainly look at it. And I mean, that's sort of what the whole point of this talk, I think, was that, I think one of the things that's been really important by having access to this surveillance data is that we are able to address emerging questions. So as things come up, as people, particularly people who are involved with making policy, come up with questions or uncertainties, we are able to, address these emerging questions and, also identify signals in the data, before they become necessarily things that we know about or that we know we need to worry about. It also allows us to validate findings from other jurisdictions. And, I just wanted to give one example of this broader science table group using findings to inform policy is that, early on, as we were rolling out our vaccinations, we saw pretty stark inequities. So residents of neighborhoods that had the highest risk of infection were the least likely to get vaccinated. And so what this led to was a change in policy where there was a very, focused prioritization of hotspots, recognizing that, getting vaccine to those neighborhoods was important and was, not working based on the current approach. So that really allowed, essentially for a pivot that was based on evidence that we were generating in real time. And so I think, moving forward, the sorts of questions that we're sort of monitoring and continuing to think about, first is the ongoing monitoring of VOCs and their impact on severe illness. And then the other one relates to vaccinations and understanding how this variable interval between doses and mixed vaccine products will affect ongoing protection from infection and severe illness. And how we can, do we need to, or will we be able to modify our approach to boosters based on the information that we glean from what happened in Ontario and the data that we're generating. And yeah, that's all I wanted to talk about. I just wanted to finalize by acknowledging my collaborators and most importantly, the people of Toronto, of Ontario, who have been generating the data and helping us work through these problems.
Thank you. That was excellent.
Thank